Hello students, I hope you're doing well. So today we want to continue with our surgical nursing 2 lecture. And last time we talked about, acute trauma life support. We looked at the things that that are supposed to, that you're supposed to do. We looked at the phases, of acute trauma life support. We looked at the different things that you can do for a patient who has sustained an injury. Yeah. So all that is embedded in what we refer to as trauma, acute trauma life support. Now, unfortunately, we cannot meet. Otherwise, there's a lot of practice that we could do as far as the topic is concerned. But when we get to meet, then we should be able to do practically the practicals that are involved as far as the course unit is concerned. But today we are going to look at something else, something different, which is within our content outline, and that is none other than pneumothorax. So by the end of this lecture, you should be able to know, you should be able to define the term pneumothorax. You should be able to know the types of pneumothorax. You should be able to know how pneumothorax is basically managed. You should be able to know how to handle certain things as far as pneumothorax is concerned. But you should also be able to know the complications of pneumothorax, things like tension pneumothorax. Now, by definition, let's straight away launch into into our presentation. Now, with pneumothorax, just like the word pneumothorax basically has 2 words, It has pneumo and then thorax, So those are the 2 words in the term pneumothorax, Now, when we talk about pneumothorax, pneumo basically means air, It is a term that basically refers to air. Then the thorax, of course, the thorax, the thorax, the chest, Now, when we talk about the word pneumothorax, it basically means accumulation of air within the pleural space, Now, it is very important for you to know that within the chest, we have the lungs, So if I might draw or if I might demonstrate something here, you have the trachea, you have the bronchi, and then you have the lungs, You have the lungs. Now, when you have the lungs, then in between is the heart, Now, the lung is basically covered by a layer, A layer, and that layer is called the pleura, The pleura. Now, the pleura has 2 parts, There's a layer that covers the lung itself, The layer, the layer of the pleura that basically covers the lung itself, So this layer covers the lung itself, Even on the other side of even this other side of the lung. Now, that layer that covers the pleura that covers the lung itself is what we refer to as the visceral pleura, So visceral pleura, And then there is another part of this very pleura which is continuous with the adjacent, the adjacent structures, So this is what we are talking about. It is continuous with the other structures, and it covers, or it is adjacent to the other structures of the chest wall, And that is what we refer to as the outer part, The outer part or the outer part of the pleura is what we refer to as the parietal pleura. Now, so these 2 are basically pleura, Now, in between the parietal pleura and the visceral pleura is a space, is a potential space, is a space called the pleural cavity. Yeah. So that space is referred to as the pleural cavity. Now that cavity ideally has very little fluid, yeah, just to to prevent friction as you breathe in and out, yeah, as the lungs move in and out, yeah, just to prevent friction. There is very little fluid, yeah, about or even less than 50 mils of fluid. However, now because it is a space that can actually enlarge, yeah, we have because of some pathology that can occur, as we are going to see, air can accumulate. Yeah, air can accumulate within that space. Yeah, air can accumulate within that space, and then the term is referred to as pneumothorax. Yeah, if air accumulates in that space, we refer to it as pneumothorax. Now, if blood accumulates in that space, we refer to it as hemothorax. Yeah, if blood accumulates in that space, we call it hemothorax. Now, so we are saying that pneumothorax is basically accumulation of air in the pleural space. Yeah, and it can occur spontaneously. By the word spontaneously, we mean it can occur suddenly. Yeah, it can occur spontaneously without any apparent cause. Yeah, or as a complication of an existing lung disease, or it can occur as a result of blunt trauma. Yeah, in other words, they stab you in the chest. Yeah, so it can occur as a result of blunt trauma or even penetrating trauma. Yeah, in the chest. Yeah, so that is what we refer to as pneumothorax. Now, we are going to look at the mechanisms of pneumothorax, yeah? And, pneumothorax can occur spontaneously. We talked about this. It can occur spontaneously, but it can also occur as a result of trauma, yeah? Now, with spontaneous, basically, as we say, the word spontaneous occurs by itself, yeah? It occurs by itself and suddenly. Now, what actually happens with the spontaneous pneumothorax is that an air-filled bleb or blister in the lung basically ruptures, allowing air from the airways to enter the pleural space. This is what we mean. Assuming you have, this is these are your alveoli. This is your tree, your broncho tree, yeah. And then you have alveoli, yeah. You have basically alveoli. You have alveoli. Alveoli are the smallest, units of gaseous exchange within the lung. Now, if by chance this alveoli, which is adjacent to the space, ruptures, if it ruptures, as you can see, it has ruptured, yeah. So if it ruptures, what actually happens is that we have air from the alveoli, escaping into the pleural space, yeah, escaping into the pleural space. Now we refer to that as spontaneous, yeah. So an air-filled bleb or blister on the lung surface ruptures, allowing air, to enter into the pleural space, yeah. Now that is spontaneous. Now, as a result, the air accumulates, yeah. Air accumulates within. So when air accumulates, what actually happens is that this space enlarges, yeah. So as air accumulates in this space, yeah, as air accumulates in this space, is basically the space enlarges, yeah. The space enlarges, yeah. And what actually happens is that the lung, yeah, the lung collapses, yeah. So we have the lung collapsing, as you can see in the diagram, yeah. We have the lung collapsing, yeah, while all this space is basically filled by the air, yeah. It's basically filled by the air that that basically escaped. Yeah, the air that that escaped here. Yeah, so you have all this space basically filled with. You have all this space filled with air that that escaped. Yeah. So now that is what we refer to as spontaneous. Now, this air accumulates until the pressures are equalized or until the collapse of the affected lung seals the leak. Yeah. So it's the air accumulates. It keeps on accumulating. It keeps on accumulating until you have a seal. Yeah. Because as the lung collapses, you know, it can eventually seal off. Yeah. As the lung collapses, it can eventually seal off this, yeah? Can eventually seal off so that no air enters the pleural space anymore, yeah? So basically, what actually happens is that when it seals off, then we have air within the pleural space, yeah? Now, how does this basically occur? It can either be simple, yeah, which affects the previously healthy people, yeah. In other words, you just have it, you just have that blade, yeah, a rupture, yeah, and then you know, you have pneumothorax, yeah. However, it can also be you know, secondary to people who have you know, COPD, yeah. COPD is a chronic obstructive pulmonary disease, yeah? So it can occur in such patients who have COPD, yeah? And then air basically escapes into the pleural space. Now that is spontaneous. Now, what are the signs and symptoms of spontaneous? One is that it is of abrupt onset. It occurs suddenly, yeah? And then all of a sudden you start feeling chest pain, yeah? You start feeling dyspnea, yeah? Now, dyspnea is basically difficult in breathing, yeah? Then you have shortness of breath. Then you have tachypnea. Tachypnea is very fast breathing, yeah? Then sometimes you can have unequal, you know, chest movement as a result of pain. And then there's what we call a pleuritic rub, yeah? When you auscultate, yeah? When you auscultate the chest, you fear, or you feel what we refer to as a pleuritic rub. Now, the other mechanism of injury is what we refer to as traumatic. Now, with traumatic, just like the word trauma, it basically means, you know, either blunt or penetrating. Like, for example, it can occur as a result of a fall. Like, for example, someone falls from a high building down, yeah? Or someone is stabbed by a knife, yeah? That is penetrating. Or if someone is shot by a bullet, yeah, you know, someone is shot, yeah, that can also be, you know, penetrating. So it's either blunt or penetrating trauma to the chest wall, yeah, and then can cause pneumothorax, yeah. Like, as you can see in the diagram, you have the chest wall, you know, as you can see in the diagram, you have, you know, a penetrating wound, yeah, on the chest, yeah, and as a result, air basically enters, yeah, air enters because that region is a low pressure area, yeah. So air basically enters and accumulates in the pleural space, as you can see. Now, it can be non-iatrogenic. By non-iatrogenic, we mean that it basically comes as a result of trauma or maybe a motor vehicle accident, you know. Or it can be iatrogenic, and by iatrogenic we mean that it is basically induced by a health worker, yeah? Like, for example, it might be as a result of lung biopsy, it might be as a result of bronchoscopy, it might be as a result of CPR. Now, when it is as a result of any of those, it is said to be iatrogenic or iatrogenic. In other words, it is induced or it is caused by a health worker, yeah? So with traumatic pneumothorax as a mechanism, it can occur as a result of either blunt or penetrating trauma, yeah, and that trauma can be non-iatrogenic. By non-iatrogenic, we mean that it can be as a result of a fall. It can be as a result of a stab on the chest. It can be as a result of a motor vehicle accident, yeah? Or it can be iatrogenic, whereby it is induced by the health worker. Now, what are the signs and symptoms of, traumatic pneumothorax? Now, usually the signs and symptoms basically present the same, yeah? Things like pleuritic chest pain, dyspnea, shortness of breath, tachypnea and the tachycardia. These are, the signs and symptoms of traumatic pneumothorax. Now, after talking about the mechanisms, yeah, we now want to talk about the types, yeah, the types of pneumothorax, yeah. So the types of pneumothorax. So there are basically two types of pneumothorax, yeah. We have what we call the closed and the open. Those are the two types of pneumothorax that we basically have, yeah? So we're going to look at one by one and also show a little bit of demonstration here and there. Now, with closed pneumothorax, just like the word closed, yeah? Just like the word closed, it basically happens when there is no injury or when there is no penetrating trauma to the chest, yeah? So it is within, yeah? So basically what happens is that air enters the pleural cavity, yeah? And the point of the point of entry automatically closes. Like for example, what we saw in, it can happen in spontaneous pneumothorax, yeah? So air enters and the point of entry closes, yeah? So this is what we are saying, that you have your chest wall, yeah? You have your lungs. You have your lungs, yeah? You have your lungs. So so you have these are basically your lungs, yeah? And then this is the rib cage, yeah? This is the rib cage, something like that, yeah? That is the rib cage. And this is on this side the same, yeah? On this side also the same as the rib cage. Now what actually happens is that air can escape, yeah, from the alveoli here, as we say, yeah, and as a result, air escapes into the space, yeah, air escapes into the space. Now, after escaping into the space, then the lung automatically seals it off, yeah, while some air has already escaped in the space, yeah, in the space here, yeah. So when some air has escaped in the space here, the lung automatically seals off, yeah? The lung automatically seals off, yeah? And as a result, you have what we call closed pneumothorax. Now, if it is not very large, in other words, if the escape is not too much, yeah? If the escape of the air is not too much, if the escape of the air is not too much, then usually, the air is basically reabsorbed, yeah, is reabsorbed, and therefore the pneumothorax subsides or the pneumothorax goes away, yeah. But however, if it is too much, yeah, if it is too much, you might have to do what we shall talk about. How do we really, handle the issue of pneumothorax, yeah? So that is what we refer to as closed pneumothorax, yeah? And it can also happen as a result of blunt trauma. There is no penetrating, there is nothing but at the outside, but you have air escaping into the pleural space. Now it can also be open, yeah, whereby with open we are saying that there's a point of entry that stays open, yeah. So you can have a point of entry on the outside, yeah. You can have a point of entry on the outside. You can have a point of entry, like for example, if this is a point of entry of air on the outside, yeah, it stays open, yeah? Or you can have the point of entry of air right from the lungs, yeah? That basically stays open, yeah? But usually we consider this, yeah? We consider the point of entry from the outside that basically stays open, because this one can never stay open, yeah? This one within the lungs can never stay open, because as the lung collapses, yeah, then it gradually seals it off, yeah? So this point never stays open, yeah? However, the point that usually stays open is the external. Like for example, if you get a stab, or if you're shot, yeah? So this point of entry usually stays open. Now, what actually happens is that maybe one thing that I should have explained in the first place is that when we breathe in, what actually happens is that no, let me first comment about the pressure within the pleural space. I did not talk about that, but the pressure within the pleural space is a negative pressure, yeah? In other words, the pressure within the pleural space is a sucking in pressure. It sucks in like a vacuum cleaner. I don't know whether some of you have carpets probably at home where you use a vacuum cleaner to clean, yeah? What the vacuum cleaner does is that it sucks the dust. It sucks the dust. Now, the same principle applies in the pleural space. Now, the pleural space is a negative pressure. Now, when it is exposed, when it is exposed to atmospheric air, it basically sucks in, yeah? It sucks in the air within the atmosphere, yeah? To a point that air enters up to a point where there is equalization of pressure, yeah? So air enters within the pleural space until the time the atmospheric pressure is equal to the pressure within the pleural space, yeah? And so what actually happens is that as air enters, you have the lung collapsing, yeah? You have this lung collapsing, yeah? So you have this lung collapsing, yeah? And you have air accumulating, yeah? You have air accumulating within the pleural space, yeah? Because of this open point of entry, yeah? So when this happens, however, there are high chances of infection, yeah? There's high chances of infection because bacteria, can also come in, yeah, and end up infecting, the lung. So there are high chances of infection, and as a result, this is why these people are always brought to hospital, and they are, covered. Basically, you cover the area with gauze, yeah, until you insert an ET tube, and until you insert a chest tube. So that is open pneumothorax, yeah. Now, there is a complication of pneumothorax, yeah. Now, this is a complication. It's not a type, neither is it a mechanism, but it's a complication, yeah, of pneumothorax. Now, what actually happens with this kind of this complication is that it develops just like any pneumothorax. However, the point where air enters from, it acts like a kind of like a valve. It's not open like you see this, yeah. For it, the point where air enters, yeah, the point where air enters acts like a valve, yeah. It acts like a valve. So if I might draw it and demonstrate it here, so it is something like this, yeah. It is something like this, yeah. So something like that, yeah. So you have an extension of the rib cage, something like that, yeah. While this part remains hanging, yeah. This part remains hanging, yeah. So when air enters, yeah, air can freely enter, yeah. Air can freely enter, yeah. As you can see, air can freely enter because that valve is pointing that side, yeah. So when air comes, it can freely enter, However, it cannot go out, because when it tries to go out, the seal, this valve basically seals it off. Yeah, it is something like this. You have something like that. Yeah, so air entering here, air can cause this part to kind of like draw in like that, so that air can enter. Yeah. However, on the other side, air cannot come back, because as it comes back, it forces this part here. It forces this part. Yeah. It forces this part to go and stand like this. Yeah. To stand like that, and therefore it kind of like seals off the point of entry. Yeah. And as a result, air keeps on accumulating. Yeah. Air keeps on accumulating within the pleural space to such an extent that it collapses, it entirely collapses the affected lung. And because of too much pressure, it even affects the opposite lung. Yeah. And even, causes the heart and the trachea to shift. Yeah. Because of the too much pressure. Yeah. So, it develops when injury to the chest wall or the lung allows air to enter the pleural space, but prevents it from escaping. Now, the pressure within the pleural space becomes positive in relation to the atmospheric pressure, and as a result, air accumulates, yeah, as with each breath, yeah. Now, the affected lung collapses, and pressure on the mediastinum shifts the thoracic organs. In other words, because of the too much pressure, yeah, these other organs, like for example, this is our heart, yeah, this is our, this region here is our heart, yeah, this region here is our heart. So it is also pushed, yeah, it is also pushed to the other side, and also the lung, this unaffected lung is also pushed, to the other side. So what actually happens is that it even causes the trachea to be pushed, yeah, to the other side. So the trachea is no longer midline, yeah. The trachea also shifts to, it shifts to that other, that other side, as you can see, yeah. Now, so basically ventilation becomes severely compromised, yeah. And for that case, a tension pneumothorax is referred to as a medical emergency, or you can call it a surgical emergency. In other words, it is an emergency. It is life-threatening. It is very, very life-threatening, yeah? So it is very important for you to know that, yeah? And that is a complication of pneumothorax. Now, with pneumothorax, as you can see in those diagrams, it has really been illustrated very well. You can see air accumulates in the, air accumulating in the, in the pleural space. Now, when you do an X-ray, of course, you have probably not encountered this, but you will find it in your clinical practice, yeah? And so when you do an X-ray, when you do an X-ray like that, you see two things, yeah? You see two things. When you do an X-ray, you see two things, yeah? You see black, as you can see, black, and you also see white or gray, yeah? So you kind of like see two colors. You see white and white or gray. Now, with an X-ray, the black basically means, in other words, the rays are able to pass through, yeah? So when the rays are able to pass through that medium, yeah, what we call transparent, they are transparent to the rays, yeah, then you will see black. Like for example, if it is air, yeah, you will see black. So where you see black in this whatever is basically air, yeah. And if a material is opaque, yeah, what we call translucent, yeah. If it is opaque and X-rays cannot go through it, yeah, then you see white or gray, yeah? And that is why you can see the ribs. You see the ribs appear whitish, yeah? You see the clavicle, you see the bones, they all appear whitish or gray, yeah? That is because they cannot allow the X-rays to pass through them, yeah? So that is what you see. Now, with that in mind, you can see the trachea here. You can see the trachea has been pushed, yeah? The trachea has been pushed to the side, yeah? And we also have air, accumulating in the pleural space, yeah? Now that is what we refer to as tension pneumothorax. You can also see there, you're seeing plenty of air. That is a sample of pneumothorax. And also here you can see a collapsed lung, and you have a lot of air there. That is also pneumothorax. Now that is how basically things appear on the X-ray, yeah? And what are the signs and symptoms of tension pneumothorax? Now we say tension pneumothorax is an emergency, yeah? You have things like hypotension, yeah? Remember, because of too much pressure, yeah? It pushes on the heart, yeah? Because of too much pressure that pushes on the heart, maybe let me demonstrate that to you. Because of the too much pressure, the heart is pushed, yeah? The heart is pushed. Maybe the pushing is from this side. So this lung collapses, and you have too much air. You have too much air accumulates here. You have too much air, and this lung has actually collapsed, yeah? So basically there is a push, yeah? This side is push, yeah? We see too much push on this side, yeah? And it basically makes this heart also, to be pushed. And as a result, there is very high pressure here. So venous return, yeah? Venous return will be very, very low, yeah? Because of the too much pressure. And as a result, the cardiac output will fall. In other words, as a result, because the blood cannot return, and therefore the heart will not be able to pump out blood, yeah? So the cardiac output will drastically fall, yeah? And since, cardiac output determines blood pressure, yeah? We know that blood pressure is equal to cardiac output times total peripheral resistance, yeah? Now, so if we have very, very little blood returning, we shall have a very low cardiac output, which will in turn affect the blood pressure. And therefore we have what a condition we refer to as hypotension. We also have shock. We have distended neck veins, yeah? The point again is that because blood is not returning to the heart, from the head region, it's not returning to the heart. Therefore, you'll have a lot of blood engorged within the jugular veins, yeah? And as a result, you'll have distended neck veins. We have things like severe dyspnea, severe difficulty in breathing. We have tachycardia. We have, tachypnea. We even have tracheal deviation. Remember, we said that this trachea also shifts towards, towards this side, yeah? It shifts towards this side, yeah? So in other words, it is deviated. It deviates from being midline, and it is, it shifts towards this side. So we have things like tracheal deviation. We have things like cyanosis, things like diaphoresis, reduced movement of the chest wall, hyperresonance. Now, by hyperresonance, we mean that when you percuss, yeah, you're going to do health assessment. When you percuss, you feel as if there is a lot of air within the chest, yeah? So a lot of air here. When you percuss, you basically hear hyperresonance. That's like you tap on a ball, yeah, on a football. That sound that you hear is basically what you call hyperresonance. Now the other one is a reduced breath sounds, or even absent, yeah, in the affected area, yeah. In the affected area, you don't hear any breath sounds, yeah. So those are the signs and symptoms, yeah. Now the other thing we want to talk about is what we call a flail chest, yeah. A flail chest is basically a fracture of two or more sides of the ribs, yeah, of adjacent ribs, yeah. So when you have two or more sides of adjacent ribs being broken, is what we refer to as a flail chest, yeah. And it might not be clinically evident at the start, yeah. In other words, you might not see it, yeah. You might not see a flail chest at the start, yeah. And so what is actually done is usually you know, they do X-ray, yeah. They do X-ray to determine you know, whether someone has a flail chest. So they do X-ray to see whether someone has a flail chest, yeah, because you might not see it clinically evident, yeah. However, if you're able to, usually the signs and symptoms are chest pain. Of course, the person that does not want to breathe, yeah. The person feels like breathing is very, very hard, yeah. And then you have things like paradoxical chest movement. Now, with paradoxical chest movement, we mean, you know, paradoxical basically means the opposite or the reverse, yeah? Ideally, when we are breathing in, when you breathe in, your chest is supposed to move outwards, yeah, and upwards, yeah? So when you breathe in, if you can try it, please. When you breathe in, your chest is supposed to move outwards and upwards, yeah? And when you breathe out, it is supposed to move inwards and downwards. Now that is a normal movement of the chest. However, with paradoxical chest movements, with someone who has a failed chest, what actually happens is that when they breathe in, the chest goes inwards, inside. When they breathe out, it goes out. Which is the reverse of what actually happens when in a normal, yeah? So when they breathe in, it goes inside, and then when they breathe out, it goes outwards. In other words, it creates a paradoxical movement, an opposite kind of movement to the normal, yeah? That is what we refer to as a flail chest. Now, the other thing that I want you to know or to know is that when we are managing tension pneumothorax or any kind of pneumothorax, we manage using a chest tube, yeah. And so we are going to look at that in a minute, but just to see some of the tests that can be done. If you can look at that presentation there, the tests that can be done with a patient who has either pneumothorax or flail chest, things like arterial blood gases, hemoglobin, chest X-ray. You can do CT scan. You can do you know, ultrasound. You can even do thoracentesis, and those are some of the investigations that are done, yeah. And these are some of the diagnoses that you should be aware about, yeah. Acute pain, yeah. These people are in severe pain, yeah. So acute pain, fear and anxiety, you know, risk for trauma, stroke, suffocation, yeah. Those are some of the nursing diagnoses that are evident in patients who have had trauma to the chest, or people who have pneumothorax or even a flail chest. Now, I want to take you through, in the next video, I'm going to take you briefly through how we manage tension pneumothorax using a chest tube. But for now, I want to give you a break. When we come back, we shall do that. Thank you so much for listening. When we come back, we shall do how tension pneumothorax is managed.